So it's my great pleasure to introduce the first speaker, Dr. Uma Borate. She's a very close friend. She's done phenomenal work in the world of CHIP, CCUS, leading the MDS program at Ohio State, and she will be telling us how to improve outcomes in CHIP and CCUS. Uma, come on.
Thank you so much for the kind introduction, and thank you for all of you for waking up so early and being here for this talk. So I always try to start this conversation because, we're trying to cure AML and we're trying to even find a new therapy for high-risk MDS, which we haven't done in, 20 years. And people are like, well, why are we talking about this? And I think I always like to, frame it as to, why are we talking about this? We're talking about this because even now, in younger, but especially in older patients, which is the majority of our AML patients, we are not curing AML. Not only that, if we try to cure AML or MDS with transplant, even then, less than half of the people who get a stem cell transplant will actually be cured and be alive at 5 years. So when we tell patients, well, we have this curative therapy for you, it's not really accurate, especially for our older patients. So that begs the question, can we do something different? Can we change the paradigm? Can we intervene early? We do it in colon cancer. We get our mammograms. We get our colonoscopies. There's a lot of precedent in cancer care to intervene early. Why can't we do that in myeloid malignancies? And I think we're learning now that there's some opportunity there. We're also learning that normal hematopoiesis is a little bit of a myth. We all are born with a certain number of stem cells, and as we age, we acquire these clonal mutations. And interestingly, it's really after the age of 60, but after the age of 70, that about 10% of us are going to have these myeloid clones that we call CHIP, but they're the same clones that people with MDS and AML will have. So there's definitely something that's brewing over time, and then in certain cases can then go on to develop MDS and AML. So, now that we found a field, we have to make it a little bit more complicated because otherwise, what's the fun in all of it? So now we have CHIP, but we have lots of CHIP. We have CH with known drivers, for example, DNMT3A, TET2A, or SEXL1, but we have a whole bunch of CHIP with unknown drivers, things that we haven't even found yet, but that we know exist and that influence these clones. A while ago, because our sequencing techniques were only so sensitive, we decided that CHIP would be defined as a clone that was found with a very allele frequency more than 2%. But that's really not the case anymore. We can sequence more deeply than that, so we can have microCHIP. We can have lymphoid CHIP because we know that you can have mutations long before people get lymphoid malignancies. And so there's a whole bunch of definitions that we have now in this field. And then the next definition that we'll talk about a lot in this talk is what we call CCUS or CCUS, which is when CHIP has progressed to now the patient developing cytopenias with the presence of clones. And that's really where we hope there's some opportunity. So, what does all of this mean? You're saying we're all developing this. You're saying most of us over 70, or at least 10% of us over 70 will have this. Are we all destined to get some sort of MDS or AML? And the answer is absolutely not. CHIP is universal, but developing a blood cancer is absolutely not universal. That's because it's context-driven. Context matters. What's happening to that clone in the person's body matters. Are you exposing them to chemotherapy? Are they exposed to radiation because of a different cancer? Are they a heavy smoker? Because these things can influence the clone that already exists. For example, if you have DNA repair clones like TP53 and you come in with radiation or a PARP inhibitor for a different cancer, that clone has a lot of potential to expand. But if nothing happens, then the clone just sort of sits there. And actually, TP53 clones have a very low rate of expansion. ASXL1 responds disproportionately to smoking. So I think there's an important message here is that CHIP by itself is not harmful. It's the context in which the CHIP exists that can then influence the outcomes. So let's talk a little bit about things that I never thought I would be talking about. My mother would be very proud. She always wanted me to be a cardiologist. I said, absolutely no way in hell, but now I'm talking about the heart because one of the biggest impacts that clonal hematopoiesis has is on cardiovascular health. And this paper came out back in 2014 where they found that just having CHIP influences people's all-cause mortality. People over the age of 70, just by the presence of CHIP, have a higher rate of dying than people who don't. And the answer is it's because of their cardiovascular mortality. They have a much higher risk of a major cardiovascular event such as myocardial infarction or stroke. And I think now I don't think I'm really exaggerating when I'm saying that people are now treating CHIP like the new LDL cholesterol. There's a lot of evidence to show that having certain clones, I would say JAK2 being the most powerful, and then TET2, it's almost the same as having high cholesterol. And this is, data that's coming out, very rapidly in the cardiology field, led out of Europe, where this now is something that cardiologists are sitting up and taking notice of. And I think this study, called the PESA study, is very illustrative because here they did not take traditionally what we call older people. These were people between 40 to 54 years of age. These were healthy people. They don't have any underlying cardiovascular risk, and they sequenced them. And they found that more than 25% of these healthy middle-aged people, aka most of us in the room, carry CHIP at a VAF greater than 0.2%, but 6% actually had CHIP at the 2% VAF definition. And these are the people that when they imaged them had the beginnings of atherosclerosis in their arteries that was associated with the type of CHIP that they had. So this is a real thing, and this is something that I think we're going to hear a lot about. But now the field has exploded in terms of associations with everything. I think VEXAS is a very extreme example. You guys have all heard about it. You're interested in it. But we have evidence with chronic liver disease, COPD, heart failure, rheumatoid arthritis. I think autoimmune diseases generally have a lot of overlap with the presence of CHIP. So I think this is important. I think this field is exploding, but most of us, oncologists, we treat cancer, and our interest is how does CHIP impact the presence of cancer. So for those of you who like Disney and who watch the movies, you always have this little evil sidekick. You have the main villain, and then you have the little sidekick that's always making the villain do bad things. And that's how you think of CHIP in solid tumors. There's been lots of data to show if you have prostate cancer, or lung cancer, breast cancer, having CHIP and having cytopenias related to CHIP, but even just having CHIP itself decreases your survival and your outcomes to do with your solid tumor. And the best sort of evidence came in the recent NEJM paper where they looked at specifically just CHIP in the blood, but also tumor infiltrating CHIP, and this was in non-small cell lung cancer, and they found that the presence of these cells with TET2 and other mutations actually impacted overall survival and relapse-free survival in the small cell lung cancer patients. And they did some beautiful experiments to show it was because of the microenvironment remodeling that these cells are really impacting, how these therapies work in these patients. So I think there's, impacts that are way beyond just, do you have a little clone or not? So, why do we care? As I mentioned before, context matters, and just like MGUS goes to smoldering, goes to myeloma, we have a flow of where you have clonal hematopoiesis. Some of us may then see patients that then develop CCUS and then can develop MDS and AML, and it's not always in an orderly fashion. Some mutations like spliceosome mutations, IDH mutations are much more predictable. Some are less predictable like TP53 and other small clones. And so I think this field is something that we're becoming very aware of. So how can we impact the health of these patients? Is there potential for early intervention? And I think these are questions we need to ask, right? We know these mutations exist. We know we can detect them. Do we have a window for early intervention? We know these mutations are found in dominant clones of MDS and AML patients. Can we target them much earlier and prevent this clonal expansion before we develop frank myeloid malignancies? So this thought came about a little bit when Dr. Malkovati and his group published a couple of papers where they really defined the set of patients with CCUS that have a combination of gene mutations that rapidly, exponentially increase their risk of developing myeloid malignancies. And I think that then really got everybody thinking to say, actually, we can identify these high-risk patients. Let's figure out a way to do it, and then maybe we can talk about early intervention. So the question in front of all of us is, can we define this high-risk population where we can justify early intervention based on the risk versus benefit calculation? And some of us, that are interested in this field wrote this paper to try to kind of parse out where do you think it's fair to intervene, and how do you take that into account? So the first thing is, how do you identify these patients? And I think at all major centers now we've developed these clinics. At Moffitt, it's called the CATCH Clinic. At our institution, we call it the HALT Clinic, where we get referrals from solid tumor colleagues, from the community, from our hematology colleagues. My favorite referring people are the lymphoma and myeloma people, because guess what? They give people Revlimid for the rest of their lives, and if they have a TP53 clone, they're probably going to get secondary MDS at some point, and then they see their counts are dropping, they come to me, and that's when we have a whole conversation about a clone, chip, Revlimid, context, all of those things. So the first thing is you identify these patients, you counsel them appropriately, you collect their samples on a serial basis, and you try to understand what is going on with that specific group of patients, and we collaborate, all of us, to find patterns. The next thing is we actually have calculators. We love math, but we all have calculators to put in information about the patient in front of us. We can put in, one of the calculators was developed by Dr. Shi from Moffitt. It's very simple. It's got 3 things. You put those in and you get a nice delineation of if the patient is high risk or low risk of progression. You have the same with the CHRS calculator, and you have one out of Europe that sort of gives you the same information. So now you have something actionable, just like the IPSSR and the IPSSM, that you can tell the patient. And I think there's a nice story coming out. So the first story that I think many of you might be familiar with is a story of inflammation and how that may reduce impact CHIP and outcomes. And this came out when the CANTO study was really designed to decrease cardiovascular risk with an IL-1 beta antibody. It's a huge study. And they found that the risk reduction was modest, but if you had a TET2 mutation, you had a 62% relative risk reduction in cardiovascular disease if you got the IL-1 beta antibody. So clearly there was a story here with CHIP patients. And there's a lot of interest in this more lately with the NLRP inhibitors, one by Novartis, that's moving forward in this space to break this inflammation expansion cycle. Maybe if we can damp down inflammation, we can prevent these clone expansion and prevent myeloid malignancy progression. So we're looking at this at Ohio State in a randomized placebo-controlled trial in high-risk CCUS patients, but we're not the only ones. There's a huge set of studies being conducted. We have Dr. Bolton leading the effort with enasidenib and ivosidenib with IDH mutated CHIP. You have a group of centers, including MD Anderson, looking at low-dose cedazuridine decitabine combinations. You have vitamin C. This was a big story at EHA last year, where they were given to patients with CCUS and low-risk MDS. And this study, I think, was very interesting because it randomized patients to a very doable dose of vitamin C, something that we all could take versus placebo. And the primary endpoint of the study was, do you reduce the clones that exist in these patients? And these were, remind people, CCUS, but also low-risk MDS patients, even some CMML patients. And the findings were very interesting. They found that they didn't really reach the primary endpoint of clone reduction, but what they found is the patients who got the vitamin C actually had a benefit in overall survival. I mean, those survival curves, any of us in oncology would be happy to see them. This was just by taking 1,000 milligrams of vitamin C. We don't understand why this happened. It was not powered for survival, but they definitely did see a pretty impressive benefit. A lot of people ask me, should I take this? I'm like, absolutely, won't hurt. So I think there's a lot in this field that we don't understand that we need to. So I'll end by saying the one thing that I think all of you may be asking your doctors, my patients ask me, is what can we do if we know we have these risk factors to change? Can we eat something different? Can we take different supplements? And Urvi Shah out of MSK is leading these really cool studies. She calls them the nutrivention studies, where she looks at nutrition interventions, which I don't think in oncology we've done in a long time. And we're going to be participating in that to see if that impacts patients with CHIP and clone size and so on and so forth. She really focuses on plant-based diets, but I think it's all something that is very interesting and needs to be studied. So I'll end by saying, we need to tread cautiously. We understand now that having CH has multiple implications for both non-oncologic but oncologic diseases. These mutations can be identified and they precede the development of MDS, CMML, AML. All of us are doing multiple efforts to identify these high-risk patients and early interception strategies. And the ultimate goal that we have is, can we use them in the right patient high-risk population to prevent complications of CH, whether it's cardiovascular or development of myeloid malignancies? But there's some pitfalls, right? Will we just end up treating a lot of worried well patients, but we won't really impact their overall survival and mortality? If we're modifying the natural history of MDS or AML, are we just doing it in very low-risk disease and it maybe wouldn't have made a difference? And I think the more provocative question, and maybe there'll be talks in this session, is CH actually beneficial for some patients, like with bone marrow failure and others, where they depend on CH to have hematopoiesis in the first place. So I want to end by thanking, this is my team at Ohio State. This is our HALT program. These are the people that see these patients and really help counsel them. And I will end my talk with any questions.
Thank you, Uma, very much. Thank you. Questions? Discussions? So just a practical thing is like, how do you follow those patients? Because obviously those could overwhelm our clinics, like, you know, and there is a spectrum. So what are your recommendations for us to follow those patients in the clinic?
So I think if they have an established oncologist that's referred the patient and it's a small chip clone that, you know, we have all these calculators that doesn't predict for anything, you know, serious happening, then we usually tell the patient, we're happy to see you once a year if you want to be followed by us. And honestly, some of it is to collect samples. That's not fair to ask the patient just to come back for that. So as long as I say somebody is following you once a year, checking your counts, we're fine with that. Anybody that's a little bit more high risk, we typically at least see twice a year. And then our CCUS patients, we see every 3 to 4 months.
Thank you.
So can I rephrase
I'll repeat the question.
Oh, yeah.
Sorry, go ahead, because it's like taped, so for the audience.
I think the question you asked, Dr. Abaza, was if you have a patient with a high-risk CHIP clone that is needing PARP inhibitor therapy for their ovarian cancer, typically, if the CHIP clone is low risk, it's not a big deal to say, yes, you know, continue with your PARP inhibitor, especially maintenance. So they don't have active cancer, it's maintenance. But if it's a high-risk CHIP clone like TP53 or PPM1D, what are our recommendations? So that is a great question because that's at least one patient a month in our clinic. And our GYN oncology group is very aware of CHIP, very aware of secondary MDS. They actively refer these patients to us to screen for CHIP. And I think I usually call the GYN oncologist and say, I found this, here's what the data shows, and we have all the articles pulled up. And then I honestly defer it to the GYN oncologist to say, what do you think is this person's risk of their ovarian cancer coming back? If it's really high, then maybe you should, knowing that they are at high risk of secondary MDS, but you can monitor their counts every month. You know, they start dropping, we'll narrow them, we can stop right away. And the GYN oncologists have these great conversations with these very well-informed women, and these women have been battling ovarian cancer for 10 plus years. And so sometimes the women have very strong feelings of yes or no as well. So I will say it's a collective decision.
Thank you, Morgan.